Here's the patient with a gauged ear, gauged up to a 0, that would like to have it repaired.
Yes, that's better.
I anesthetize the
Okay,
ear
ready?
with
Yep. Okay.
1/4%
So before
Marcaine
I
as
do it,
well as
I just
1%
give a little
lidocaine. I
shake.
shake the ear when I
You
place the
feel much?
needle,
No. Good.
and the
Real
patient doesn't
local, real
feel the
slow on the
local as
local.
much, the stick of the
Just a
needle
little
as
bit. You
much.
okay?
Oh yeah.
I typically perform 2 small injections at the base of the lobe. You may or may not feel that. Did you feel that?
Oh,
and one
good.
injection on the outside of the defect. One little stick here. You may or may not feel that. Stick.
Oh,
Good. You didn't feel that? Good. So that's pretty much it. You're pretty much
Sweet.
numb.
nice.
Was that pretty easy?
Yes.
Okay. I want you to take your right hand and just kind of do massage it a little
Okay.
bit. That's okay. I just want his ear.
Mm-hmm.
Okay. First of all, I'm going to test you. Okay. Does that bother you?
No.
Does that hurt at all?
No.
Okay. So I designed an elliptical incision around the invagination of the ear, where the ear wants to fold on itself. I want to create a level surface across the ear lobe so that you don't see that turned down appearance. So to start out the procedure, I simply want to ellipse around it and recreate a defect to where both halves of the defect are going to be level. There are a whole bunch of different ways to do this. You can stair step it. You can create multiple flaps, interpositional flaps. I generally find that those are difficult to create and create strange shapes on the ears once they're healed. I prefer an elliptical incision and then what I call Tailor tacking, or trimming the ear to create a curvilinear scar. So here I'm using a 15 blade to simply elliptically incise out the earlobe where the earlobe folded upon itself. In essence, recreating a defect in the ear where the two halves are level. Once I incise the skin anteriorly, I use scissors to trim out the posterior portion. I find this much easier to perform, and I have a lot more precision performing it with scissors cutting through the back of the posterior portion of the ear skin. Now I have two halves that both curve toward one another. That curve, after I perform hemostasis, the curve allows me to create the S curve in the ear. And as you can see, I can either curve toward the face or I can turn the curve away from the face. I thought that the lower lobe would look better coming out, so I'm going to use the curve of the lower lobe to join a curve that I create on the upper lobe. And again, generally I'll draw the straight line and then I'll slightly curve it away so that I keep the curve as slight as possible. One of the great reasons to do a curve versus just a straight line excision is less longitudinal contraction of the actual scar. And by the longitudinal curve, it fractures up the longitudinal vectors of the scar contracture and generally results in a better earlobe repair and a more aesthetic earlobe repair. I'll trim out vertically as well toward the base of the ear. And now I have my general S curve, and you can see as it starts to come together, it has a natural flow to it and a natural inferior shape to the lobe. I generally put only a single either 5/0 or 4/0 vicryl on the inside of the ear to oppose the edges and to provide some internal support as the patient heals. This can be difficult to place because it's hard to get the internal stitch matched up, and it may take a couple times to get it just right. But this is a really critical stitch to make sure that you get correct. And they should line up in the outer edge of the lower lobe, which I'm getting ready to suture. This is the critical step. Just like the white roll in the lip when you're doing a cleft lip repair or lip laceration repair, I think the inferior curve of the lower lobe is the key stitch in the whole case. To get that curve lined up and the edge lined up as well as you can. You can accept a little bit of eversion here and a little bit of notching because it will settle down over time. But that first stitch is the critical stitch. And as you see it come together, you can see that the outer edge of the ear line up pretty well. And then what I'll do is I prefer interrupted stitches. I don't like running stitches on the ear. And it's very critical. See how I have my two curves? Is to get those curves lined up as precisely as you can. So I generally use 5/0 Vicryl on the ear. You can use 6/0 as well. I think 5/0 does the same job and it's easier to see and get out. I generally put more sutures on the anterior portion of the ear and get it lined up, and fewer sutures on the posterior portion of the ear to allow it to drain any blood that's going to drain out. And you typically don't see that side of the scar anyway. And here's the final result. A nice shaped ear, a great inferior line to the eye, and overall excellent repair to gauged ear. I leave the sutures in for about 6 days. I remove them and then place mastosol and steri strips around the lobe to provide a little bit of compression. I do this for about 2 weeks, and I allow the patient to re-pierce the ear in about 3 months, but obviously no further gauging of the ear. Thank you.